Hello, welcome to the live streaming. I've not done a live session for a long time and I thought I'll try it out today. And the other thing is that I will try live stream mainly for parenting topics because the medics are busy and they usually like to catch up at their own pace. So today I will be covering a few topics which deal with common concerns faced by new parents. For those of you who have not attended a live stream before, I would like to introduce myself. I'm Dr. Sridhar. I'm a consultant neonatologist and currently I work at Alain Mediclinic. And I'm a consultant neonatologist. For those of you who wonder what a neonatologist is, I mean, they're dealing with newborn babies care. We are primarily pediatricians. And then we specialize to manage newborns, especially in the neonatal intensive care. About 4 years since I started this YouTube channel during the peak of the COVID, May 18th, 2020, and subsequently I've been consistently sharing videos in terms of parenting as well as for medical personnel. And I would say it has been fairly satisfying. I've had very good feedback from all of you and many comments requesting support as well. So one of the key aspects that I tend to cover is common concerns with parents, breastfeeding, and so on in terms of parenting. And many of you do ask questions. I have a short video on how to navigate the channel, and the easiest way probably for you, as the channel has grown so much, is to just comment on any of my videos related to what you want to know, and I can share a relevant video which is already there on the channel, or consider making a video on that topic if it's suitable. So just remember, commenting on any video is fine, and you can just mention what you want to know. Most of the time there is a video relevant to that topic already, so just share it. And in terms of perusing the channel yourself, try to go through playlists, and the playlists for parents have different segments: breastfeeding support, skincare, viral infections, fever management, and so on. So that would be helping you manage as well. So moving on to a few discussions. So as you can see, these parents are happy and content with their new baby, and all the new parents, all the expectant mothers are anxious to an extent to understand how it's going to pan out. So first of all, calm down. There is nothing to panic. You have professionals to support you right from the time you get pregnant. Your obstetrician, the nurses in the antenatal clinic will answer your questions. Learn more about breastfeeding when you're pregnant itself, because that's the best time to know more. There is a concept called antenatal expression. There is a video on my channel on that. So you can start discussing it with your obstetrician when you reach 36 weeks. So that is one of the ways to establish the breastfeeding faster, so that in case your baby needs support after birth, we don't need to use formula. So the key aspect I would discuss today, the first topic is breastfeeding support. You might wonder why I'm talking about breastfeeding first. So it's a most natural progression. Once you deliver the baby, you want to cuddle the baby, you want to bond with the baby, and you want to breastfeed. So nature has designed us in a way that the mother has to start breastfeeding, has to bond with the baby, her hormones kick in. There is a balance of different hormones which regulate the milk output, and this balance happens at the transitional stage. When you're in labor, this process starts, and after the first day or so, as the baby starts suckling, you start producing. The breast is already ready to produce milk, but the milk isn't starting to come. Those who have had babies before, you might find a different experience. You might start secreting milk towards the end of pregnancy because the breast is already primed. There are stages of milk output, lactogenesis, so to speak. So the breast is prepared already. That is the stage of lactogenesis 1. And the milk output that I described is lactogenesis 2, and successful lactation is lactogenesis 3. So during this lactogenesis 2 is when the mother and the baby learn to feed the baby and the milk starts coming. All of you are aware of the concept of liquid gold. The first 2 to 3 days there is a milk called colostrum, and this is crucial for the baby to get, because this is very rich in protective factors for the baby. So it's very important that we don't miss out on the opportunity, and we suggest skin to skin care from the moment the baby delivers. and you start suckling the baby as soon as you are able. Do it every 2 to 3 hours in the first few days, and this is going to naturally set the process. One important point here is that the parent should be aware the first 2 to 3 days is when this milk establishing process happens. Colostrum comes in a few drops on the first day, and it goes up to 3 to 5 ml per feed on the second day, and maybe 10-15 ml by 3 days. If the mother is on medication, she is hypertensive herself, or post cesarean section, this process may be a bit slower, but you need to start supporting. If the baby is high risk, for example, you had diabetes during the pregnancy, or if the baby has issues related to growth, premature baby, small baby, and so on, we start requesting you to express milk. One of the key things that needs to happen is for the milk that is starting to be produced to come out of the breast. So that needs milk transfer from the breast to the baby, and unless this happens successfully, the baby may not be able to successfully breastfeed. So if the baby is not sucking or not too keen to suck or is not latching appropriately, you need to express milk. The latch, which I mentioned, is a key component of how successful the breastfeeding will be, and this is nothing but the way the baby attaches himself or herself to the breast in a way that the milk is successfully going to come out without hurting the mother as well. So your lactation consultant or your nurse might be able to guide you on this, but read a bit about that so you're mentally prepared. As I said before, if you have breastfed successfully before, this comes naturally to you as a mother, but for the baby, it's still at a learning point, and you need to adjust to each baby differently. Don't be anxious about the amount of milk you produce. A baby is absolutely fine with the small quantities we produce, and that's one of the key reasons why either parents or their relatives, like the grandparents, want to start giving some formula till the mother's milk comes. So this is a crucial mistake, because if you start giving formula, it's going to beat the natural process. The mother's breastfeeding doesn't progress as well as it should. So it's a natural thing that you're disrupting a process that should happen in a certain sequence. The baby also gets confused with the volume of milk reaching the stomach. So I'll come up to that point of vomiting next, but a baby's stomach is very small to start with. The first day, it's the size of a pea, and then it goes up slowly. So just 3 to 5 ml milk can be held in the newborn stomach in the first day, and then it rapidly expands if you start giving more. So there is a reason why the stomach is small on the first day, because the baby doesn't need to get the milk. The mother's milk is going to come slowly, and when the milk starts coming, the stomach starts distending and the baby can accept more without vomiting. Suppose we give formula on the first day, like 15 or 20 ml, the baby's stomach distends suddenly, they start vomiting. They're already prone to vomiting due to the stress of labor, which I'll explain next as well. So the commonest mistake is to give formula when you can actually manage with breastfeeding. Where there is a risk factor, like you have diabetes, you have twins, or you have a risk of preterm labor, after 36 weeks you can start expressing, and this stimulation and getting the colostrum out makes the breastfeeding successful. So even if the baby has a risk factor, we may have some milk in store, your own milk can be given to the baby. So resist giving formula unless it's essential for medical reasons. One of the reasons can be that the baby sugar is monitored for any reason and it comes on the lower side. But even there, it doesn't mean you need to continue the formula. You just need to give the formula for 2 or 3 feeds till you start producing enough, and you need to work on getting the latch right and possibly start expressing as well. And in case you have started formula for any reason, try to stop it at the earliest possible, because the longer the baby stays on it, the more they get used to it, and the more it's going to disrupt your own milk output. So this is the critical point about starting with breastfeeding. And the question of how much to feed the baby often comes up. So this is not an easy question to answer. Primarily, it depends on the baby's requirements, and each baby is different in how much milk they need. For example, if a baby is exclusively breastfeeding, what we say is don't worry about how much the baby is getting, as long as the baby stays satisfied, and how much weight gain is there, how much urine output is there, is going to guide you. Again, the weight gain pattern differs from baby to baby. It depends on the baby's own growth centiles. So if a baby is small at birth, they may continue to grow on the smaller side. So don't expect them to grow faster or to feed more just to gain weight faster. So allow the natural pace to take over, and you have to familiarize yourself with growth charts. I have videos on growth patterns. If a baby is growth restricted, making them grow faster isn't good for them. So that is one of the important things that you should be familiar as well. So if the baby is starting to breastfeed in the first 2 to 3 days, it will be every 2 to 3 hours. Frequent feeding is important for the milk to start coming. And as the feeding establishes, the mother's milk starts coming in, you see that the baby is starting to sleep well, the baby passes more urine, and this will ensure that the weight gain is continuing as well. If the baby is slightly jaundiced, don't be worried, because some jaundice is normal, and the doctor will be arranging to monitor the jaundice as well. So the first 3 to 5 days, there may be a slight gap between the mother's production and the baby's ability to take the feed. So especially if you have previous babies, your milk starts coming in faster than the baby can cope. So you might feel engorgement. If the breast becomes hard at this stage, you may need to express some milk before the feed. And if the baby is agitated, you can give that express milk in a cup to calm down the baby, and then keep the baby on the breast. So this will help the baby to settle down better. Sometimes the milk spurts when the let down reflex is strong. In these cases, you can feed the baby lying back and keeping the baby slightly up, or the same technique which I explained, express a little bit and then start feeding the baby. This would help as well. So choking during feeding is a concern, and there is a video I've shared earlier. If you're worried about that aspect, drop a comment and I can share the link with you. If a baby for any reason needs formula milk, as I said, support the milk output yourself. Use a breast pump as far as possible for every feed. After the baby has fed from you, express milk, and use that instead of using the formula. That will ensure that your milk production is increasing and you're not relying on the formula. However, if for any reason you need the formula at a regular pace, for example, you start at work and you don't have enough milk stored, the quantity to feed should be again decided on whether you are doing mixed feeding. If you go too fast on the formula, the baby will not be satisfied with the direct feeding at any stage, because they are not going to get that much from the breast directly. So the confusion may cause the baby to tilt towards, or the parent gets stressed and tilts towards the formula feed. So anything we do, we should try to keep the breastfeeding in priority. So the tin of the formula advises you of a certain volume. I request you don't follow that, just ignore it. Look at how much you are expressing at each feed and consider that as a volume that the baby may take. For example, in the first month, the baby takes 60 to 90 ml per feed every 3 to 4 hours. If your baby is breastfeeding, they may feed 2 to 5 hour interval. So I suggest that you don't rush to feed the baby immediately. If baby cries after half an hour, 40 minutes, you try to hold the baby, cuddle, and check for other reasons why the baby is crying. Because the quicker feeds gets into a snacking pattern, the baby takes small frequent feeds and doesn't settle down well, and it leads to more problems with colic and passing excess stool. So you can have 1.5 to 2 hours as a reasonable minimum gap, and if the baby starts sleeping well, the once you know the milk has come, the weight is increasing, you can allow the baby to sleep 5 hours at a time. The formula milk or the express milk, if you're exclusively feeding that, you will need 60 to 90 ml, and the 60 to 90 range depends on the size of the baby and how frequently they are feeding as well. The next month you can increase by 30 ml or so from that level, and again it depends on the gap between the feeds. The babies can start sleeping 5 to 6 hours by the second month. You don't need to wake them up in between that if they're sleeping. If they have a pattern of sucking feeds too often, if you are on bottle feeds, try to space it more. If you're on breastfeeds, you can titrate, leave it to the baby's demand, but don't over-interpret the baby's hunger cues and overfeed, because that's not ideal as well. One important concept here again is physiologic lactose intolerance. So the lactose is a milk sugar, and there is a certain amount of lactase enzyme that the baby has at the beginning. It quickly upgrades as the baby gets exposed and to the milk, and the digestive ability of the lactose increases. But this is a gradual process. It takes 7 to 10 days, and if you are exposing the milk, too much milk in the baby to too much milk in the early stages, like if you are multigravida and you're feeding more than you need to feed, or if you're bottle feeding the baby starts getting colicky or has abdominal discomfort. So you start worrying that the baby is hungry and you start feeding the baby more. This leads to a cycle of reflux and vomiting as well coming on top of that. So remember that here you are starting the problem yourself by giving the baby more milk than they can digest. They don't really need extra volume in the initial stages when they are learning to digest and cope. So please remember this point. And overfeeding is a common problem and it leads to reflux. The baby has more colic. If you have an excess lactose load, they may pass loose stools, get nappy rash as well. This is called physiologic lactose intolerance, which is aggravated by our giving more milk. So try to titrate the milk volume to your baby's needs, monitor the growth on the growth chart proportionate to the baby's centile, and don't be pressured to give more milk because the baby cries more. Around 4 to 6 weeks, all babies get colic, and you can tolerate it. You can manage it with some variations in your routine handling, but it tides over eventually, and you don't need to be worried about it. So the next point I'll address is head support for a baby. So many of you might have seen a head support similar to this for a newborn baby, and one of the reasons these come into the picture is because of the predisposition to flattening of the back of the head. So if the baby tends to prefer to lie on one side, either the head gets elongated or it gets flat on one side and starts bulging out on the front on the other side. So this is a common problem called plagiocephaly. In a premature baby or a growth restricted baby, their skull is fairly soft, and elongated skull is quite common as well. So it's always good to keep the head in the midline if possible, and these kind of supports can assist you. The other thing you can do is rotate the baby tummy time when the baby is awake. Don't allow the baby to sleep on the tummy till the first 3 to 4 months. Again, if you have questions about sudden infant death risk, message me on the YouTube by commenting, and I will share the relevant video with you on how to prevent it. So the main component here is that the part where the head will rest will be hollow. The sides are raised on the 3 sides. It's like a horseshoe, but the part where the neck is resting should be flat. So it shouldn't be raised, because if the neck area is raised, it may cause the head to bend down, and that blocks the breathing, and babies are not strong enough to move themselves easily. So you should make sure that you're buying the right support. There are many duplicates which come like a full circle, which is like quite thick all around, and invariably it will cause problems with the neck bending. Remember that anything that obstructs the baby's airway, don't have any broad sheets on the bed, don't have anything loose or soft toys on the bed. So anything that obstructs the breathing is not safe in the immediate period. Same way with the co-sleeping with the baby. If you're tired, don't put the baby on you and sleep, and don't breastfeed and sleep at the same time. It's always better to be reclining or sitting up while breastfeeding. One of the reasons is that if you lie down and breastfeed, there is a bigger chance of the milk reflexing up. We have a connection from the inner part of the throat to the ear. It's called the eustachian tube, and it's quite short in babies. And this milk regurgitating against the eustachian tube causes some inflammation, and some babies come with even perforated eardrum with milk-like discharge. It's not infection, but it's due to the regurgitation and the milk flowing out. So this obstruction of the eustachian tube may cause the baby to be uncomfortable and cry excessively as well. So remember that if you lie down and feed, there is a chance of ear congestion and even perforation of the eardrum in the small baby. So try to be reclining or sitting up, and try to be alert as far as possible. Even though we advise feeding and sleeping in the lactation courses, I mean, it's not absolutely safe, and it's better to be alert and feed and sleep back again. So this is another option to position the baby slightly upright. There are babies who have excessive colic or reflux, and keeping them about 30 degree up is useful. These have straps as well, which will keep the baby safe, and right from 10 days to 2 weeks onwards, you can start using these. These are called baby bouncer chairs, and car seat can be used for the similar purpose as well. During the night, you can keep the baby in a basket next to you. Baby baskets are available, and you can elevate that by keeping something underneath the basket to slope it. Folding a towel is okay, but it should be sloping the whole baby. The position, the sloping is not needed in all babies, but those who have proneness to reflux and crying episodes or spitting up frequently, you can consider using this. And of course, the baby starts looking around, and it's a good aspect to monitor. Positioning the baby this way reduces the effect of gravity on the head shape. So this is another way to avoid head shape abnormalities. So when the baby is born, in the first 2 to 3 days, many parents may notice that there is a pink stain on the nappy. This is especially so if you are exclusively breastfeeding. As I explained, the first 2 to 3 days, the milk output is low. And when the urine is relatively concentrated, the crystals in the urine, especially the urate crystals, may crystallize, and this leads to a pink stain. This is absolutely normal. It's not blood, and it goes away once you start feeding well. If you see it and there is an associated excess weight loss or the jaundice is increasing, it might encourage you to start expressing in addition to direct feeding till your milk output is good. So for 2-3 days, you may need to stimulate the milk output by expressing. Again, discuss with the lactation consultant regarding that. But this is quite normal and you don't need to worry about it. It will pass. On the first day, many parents notice whether the baby is born by normal delivery or by cesarean section. The baby starts vomiting. They gag a lot, they tend to retch, and they may bring out mucus or blood-stained secretions. The blood staining is nothing but the swallowed maternal blood during the delivery process, because the amniotic fluid surrounding the baby gets contaminated with the mother's blood, and obviously this is swallowed by the baby during delivery as well. So there are many reasons why the baby is vomiting, because the stress hormone levels are very high around the labor process or around the delivery time. If a baby is born by cesarean, the medications that are given to the mother to sedate her or to really give her pain relief or to anesthetize have side effects on the baby as well. So it can be related to the stress hormones being high in the system. It can also be because of the medication effect. So either way, it settles down by 24 hours or so. Giving the baby a formula feed because the baby has hypoglycemia or some other factor makes this to be more. If the baby keeps doing this, sometimes we give a stomach wash where we put a tube into the stomach, feeding tube, give 10 ml or saline or so, and remove it. We should be careful to make sure the tube is in the stomach before we give the saline, as there is a risk of aspiration. So again, we only do this if it's essential, if the baby is uncomfortable and this is repeated. If it's occasional vomit, reassure the parents, turn the baby to the side and avoid giving excess feeding. Even if you have to give top-up feeds, give only 10 ml or so, as excess feeds will distend the stomach and cause more vomiting. Again, I mentioned in the beginning about breastfeeding support and not to give formula as far as possible. This is another common concern. A mother comes from home with a bloodstained vomit. Obviously, seeing a bloodstained vomit from her baby is extremely nerve-wracking for a parent. If the baby looks well, however, you don't need to panic. The most common reason for this, especially in a primary mother, is because she's trying to breastfeed, and cracked nipple has happened in the baby during the process of sucking. The blood from the breast is going into the baby's stomach, and obviously the blood is irritant and the baby vomits. So if you see the baby, you need to confirm that the baby is well. There are no concerns, no risk factor for infection, and make sure that the vitamin K injection is given in the newborn period. Again, you might already be aware of the reason vitamin K is given. It's to help stimulate the factors needed for clotting, and all the babies receive the vitamin K in the newborn period. So if you notice this, the mother can still continue to breastfeed, but make sure that the positioning is correct and she's looking after the breast well. So the latch being inadequate or improper is the commonest reason why the crack happens. So she has to take care of the skin. She has to make sure she's not continuously suckling the baby. So she may need to start feeding the baby for 10-15 minutes with appropriate latch and then express milk to save herself. A nipple shield is an option in these situations as well. Again, discuss with the lactation consultant about this. So one of the important things that keep changing in newborn babies is the stool pattern. Obviously, each baby has a different stool pattern. In the first 2 to 3 days, the baby passes a very thick green-black stool. It's called meconium, and it's dark green because of the bile that is in the intestinal contents that accumulates during the stage the baby is in the stomach of the mother. And when the baby passes the meconium after 2-3 days, the stool starts changing color. So you can see the transitional changes. So you can see the dark stool lightening green. As the milk starts coming, the stool lightens more, and you get the mustard color, the yellow mustardy seedy stools in the breastfeeding babies. Again, as the milk volume is increasing, you start getting frothing and watering. I explained the physiologic lactose intolerance earlier. So this is important for you to understand that physiologic lactose intolerance is normal. When the milk starts coming, the baby starts showing these symptoms. But again, at this stage, you know the milk is coming, the weight has increased, the jaundice is stable. So you can start waiting longer between feeds. You have already established lactation, so you can allow the baby to sleep longer if the baby is sleeping. Don't try to wake up the baby every 2 hours. Again, if the stool pattern becomes greenish but it doesn't change to yellow, it's still normal. A green stool is normal, and little mucus coming in the stool is normal. Breastfeeding babies have a very variable stool pattern. Once they start digesting the milk well. Once their lactase enzyme has reached a good level, they may not pass stools for 3 to 5 days. So this typically happens after 10 to 14 days, so usually in the third week onwards, and it can continue till you start weaning the baby. So the baby may pass stools every 3 to 7 days, is absolutely normal. The tummy is soft, and when the baby passes stool, it's always soft. So this pattern is very normal for a breastfeeding baby, and you don't need to give a suppository. Of course, make sure that the thyroid is normal. It's part of the newborn screening, and once you know the newborn screening is normal, there is no need to worry about it. In a mixed feeding baby, if the stool starts getting hard, that means that you need to try and increase the proportion of breast milk, because breast milk is a natural laxative as well. And if you are on formula feed, sometimes we may consider giving prune juice or water to soften the stools if the stool becomes hard. I have some blogs on these topics, so again, I can share the link if you need. Drop a comment on any of the videos. Very important concern in babies is neonatal jaundice. Again, I have detailed videos on neonatal jaundice, but from a parenting perspective, the most important thing is to know that the jaundice is a normal progression. The baby has excess hemoglobin while within the tummy, and after the baby is born, this excess hemoglobin gets destroyed, and the yellow pigment called bilirubin is a result of that. We monitor all babies for jaundice because there are some babies at higher risk. For example, if your blood group is O and the baby is AB or AB, or if you have antibodies against the baby's group in your blood, the baby has a tendency to excess jaundice. Premature babies have risk of jaundice, and we have age-appropriate charts which guide us on the treatment. So the nurses will check the jaundice usually with the skin test. We refer to the charts according to the age of the baby and decide on the treatment. A baby born at 36 or 37 weeks has a much lower treatment threshold compared to more mature babies born after 38 weeks. So the longer the pregnancy progresses, the more mature the baby is, the quicker they feed. So for any reason you discuss delivering at 37 weeks, try to wait longer as far as you can. And even the IQ has been shown to be better in the more mature babies. So if you have an emergency and you need to deliver at 37 weeks, it's fine. But if there is something else you prefer to deliver early, you try to postpone it, discuss with your doctor. So the jaundice is usually checked before you go home, so we know when the baby needs to come back. There is a threshold for the visit. If it's high, we need to come back even the next day or within 2 days and so on. And once we see you in the clinic, again, we do the skin test, review the feeding, the weight pattern, and then if needed, we may do a blood test for the jaundice, and some babies may need to admit for what we call phototherapy. Don't be worried about it because this is natural, and unless the level is very high, it shouldn't affect the baby in any way. In the breastfeeding babies, the yellow color on the skin can persist for 3-4 weeks, and in some babies it can even last for 2 to 3 months. So this is quite normal as well. The doctor will be checking around 2 to 3 weeks for direct bilirubin, which is a component of the liver function, and the stool color should never be pale. Because a pale stool may also indicate a liver abnormality. Provided these are normal and the thyroid is normal on the newborn scan, you just continue breastfeeding. Even if the bilirubin is a little high, it doesn't matter. You can refer my videos on breast milk jaundice, which is explaining this in more detail. But if you are breastfeeding, try not to stop breastfeeding just because the jaundice is on the higher side, unless it's absolutely essential. The umbilical cord care is very important. In the immediate newborn period, we always suggest to keep the nappy folded below. So if you cover the nappy over it, it may start smelling, it gets more wet, and it may separate in a wet way, which breaks here, or for example, not ideal. The nappy folding, the plastic side should be out, so the absorbable side comes right to the top, especially in a male baby. If you fold it inwards, the urine may come out and soil the nappy area. The cord can be washed and things, but you don't need to use alcohol or powder on it. Keep it dry, and once it starts separating this area, you would spread it open and clean inside with alcohol swab. It may be sticky. Some blood spotting is normal at that stage. If you clean it once a day or so with alcohol swab, it improves by itself. And sometimes you have a residual granuloma at the base. A small granuloma disappears on its own over 3-4 weeks if you keep it clean and dry. However, if it's persisting, you can refer my video on granuloma where I discuss salt application. There is a blog on this topic as well. So this is the normal course. So main thing, soon after the baby is born, keep the nappy folded below. No chemical disinfectants, as it will cause delay. Some babies who get antibiotics in the newborn period, it may cause delayed separation, but it doesn't matter even if it takes 2 weeks or so to fall off. So this is another common concern that parents have. The babies receive the BCG and hepatitis B vaccine at birth, and the BCG is given in the left shoulder area, the deltoid area. The BCG is for the tuberculosis. It's a live vaccine, and the reaction of the vaccine takes place over 4 to 8 weeks. In this form, you see a small swelling. It may form a blister and break, and it may break 2-3 times. You just have to keep it clean and dry. No need to use antibiotic powder or cream over it. Some babies, it's a little exaggerated, and some babies may get a lymph node enlargement under the armpit as well. So these are all common reactions which are normal. So if you see this, no need to be worried about it. What is the feed pattern in a baby? I already discussed it when I discussed how much to feed, but remember that in the first week when the milk is still establishing, you try to feed as often as the baby needs, every 2 hours, or at least 8 feeds in a day. Each feed duration is also not controlled in these situations. After the baby starts feeding well and your milk output has started, you allow the baby to regulate, but make sure you're not over interpreting the hunger cues. So a reasonable pattern you would expect is between 2 and 5 hours. The older babies can start sleeping longer, but this happens more in formula fed babies. Breastfeeding babies tend to feed every 2 to 4 hours usually. The duration of each feed again varies, but if the baby starts vomiting after a feed, it may mean that there is overfeeding, and you may need to titrate both the frequency of the feeds, allowing some spacing, and the duration of each feed. I mean, if you're feeding for 20-30 minutes after the first week, it may be longer than the baby needs. So you can start shortening it, and some expert babies feed by 5 to 10 minutes, the full feed can be taken. You can also start alternating breasts. So initially, you would feed on both breasts at each feed, but once your milk output starts, you alternate the breast so that the baby gets the full milk output. The hind milk is important for the fat and the satiety part, and the full nutritional value. The fore milk is watery and rich in lactose. Baby takes it more in the summer for thirst. But in terms of feeding, emptying the breast is important, so you complete the feed and baby may be satisfied with feeding on one breast and alternating. At night, just before you sleep, you can feed on both breasts so the baby gets a little more and sleeps longer. So another important tip that a new parent should know is how you give drops to the babies. We give vitamin D drops, and sometimes we do give something like simethicone, though the effect is not clear cut. Parents do prefer to give something if the baby keeps crying. So the drops has to be directed to the side of the cheeks. Don't drop directly back, as the baby may not be expecting it and they may choke on the drops. Once you drip it slowly, the baby tastes it and they start swallowing. So then you proceed with giving the drops. Be careful about the dose of vitamin D. There are many preparations in the market which are concentrated. I personally don't prefer to give the concentrated drops because there is a higher risk of overdosing. And in case the preparation you're using changes for any reason, be very careful. Baby needs 400 units a day, and read it on the container as well before you decide to give. So the 400 units is usually achieved in 1 ml, but if it's a concentrated drops, that is achieved in 1 to 2 drops. And if you give 1 ml of that solution, it's a very high dose. And vitamin D at a high dose can be toxic. It leads to high calcium levels in the blood. The calcium may deposit in organs, including the kidney, and it's not safe. So if you have been overdosing for any reason, you need to inform your doctor, but be careful with how much vitamin D you give and how you give it as well. There are situations when we decide to give a higher dose, but that is not routine. So I've covered many questions in this, but if you have any questions from your side, let me see if there are anything in the chat box. So I don't see any comments, and if you have any questions, I'll wait a minute or so before we close. I can do this more if you find it's useful. So drop your comment on whether you want to continue this. And again, I'll be sharing these as smaller individual videos as well from this live session. If you have any topics you want me to cover again, you can let me know. So I think I'll close here. Thank you.